Lacrimal diagnostic probing and irrigation is an anatomical test to examine the patency of the proximal lacrimal system and also the nasolacrimal duct using a lacrimal cannula. This is not a physiological test, as irrigation occurs at a higher hydrostatic pressure than normal physiological transit of tears. A careful, more systematic and analytical process to syringing can actually help identify the presence of a subtle stenosis or outflow dysfunction of the nasolacrimal duct that may be reducing tear outflow under normal physiological conditions and causing epiphora, whilst the lacrimal system may appear patent to traditional methods of irrigation. Using this method of lacrimal syringing can reduce the need for ancillary tests such as dacrioscintilography or dacriocystography with late erect films. And in the vast majority of cases of epiphora due to lacrimal outflow dysfunction, where syringing appears to be patent. Make sure the patient is comfortable with their head supported by some sort of headrest. It can be helpful to anesthetize the conjunctiva and with topical anesthetic, particularly if planning to probe and syringe via the upper canaliculus. My preference is to use a thin 26 gauge smooth curved lacrimal cannula on a 2.5 ml syringe filled with saline. I prefer saline to water because when performing lacrimal syringing bilaterally, it is easier for the patient to detect and taste as irrigated fluid passes through the throat. It also allows the patient to report any differences in the delay between the two sides before they taste the fluid. Also, warn the patient that the irrigated solution will feel cold around the eyelids. Good illumination and loop magnification is helpful. Wearing a dimly lit headlight may be more comfortable for the patient rather than an overhead light. Diagnostic probing and irrigation of the canaliculi and sac is preferably performed first through the lower punctum, as any disorder of the lower canaliculus will be more symptomatic than that of the upper. Always stand on the ipsilateral side that is being probed and irrigated. Ask the patient to look up and gently pull the medial eyelid down, and at the same time stretch the lower eyelid slightly laterally. Using a 26 gauge lacrimal cannula avoids the need for punctum dilation in the majority of cases, unless punctal stenosis is encountered. Whilst maintaining the lower eyelid slightly everted and laterally stretched in order to stretch and straighten the canaliculus, the lacrimal cannula attached to the syringe is inserted into the punctum vertically. Then, at approximately 2 millimeters, the tip is slowly pivoted horizontally to pass through the horizontal canaliculus. Gentle lateral traction is maintained on the eyelid to help straighten the horizontal canaliculus while slowly advancing the cannula. Stretching the lower eyelid laterally avoids allowing the canaliculus to kink as the cannula is advanced. Allow the cannula to gently lead rather than pushing with force, and carefully feel for any stenosis or obstruction. Mid-intracanalicular irrigation is performed and careful observation is made to note the proportion or percentage of this fluid that is regurgitated back either through the upper canaliculus or lower. In addition, particular attention is also given to the presence of any mucus in this initial return of fluid. The presence of any mucus within this initial fluid return is highly suggestive of some degree of outflow dysfunction of the nasolacrimal duct. The degree of resistance encountered to irrigation is also noted. This is a subjective observation and one that needs some experience in order to determine its correlation with the presence of nasolacrimal duct stenosis or partial obstruction. However, comparing this to that of the opposite side provides an instant comparison to the clinician for correlation between the more symptomatic side in unilateral epiphora or where symptoms are greater in one eye. Fluid regurgitation from the upper punctum also helps exclude the presence of a complete distal lower canalicular obstruction. Again, stretching the lower eyelid slightly laterally to straighten the distal lower canaliculus, the canalicular is advanced into the sac to very gently touch the medial wall of the sac and adjacent bone. This is described as a hard stop and should be encountered very gently in order not to cause pain. A hard stop indicates that the tip of the cannula is now beyond the common canaliculus and into the lumen of the lacrimal sac. If the sac cannot be entered and a spongy obstruction known as a soft stop is encountered, then firstly, carefully observe for any distortion of the medial canthal angle that may be occurring as the cannula is being advanced. This may be due to a distal lower or common canalicular obstruction. It may also be the valve of Rosenmuller, a fold of mucous membrane found at the junction between the common canaliculus and the lacrimal sac. However, it is often simply due to a kink approaching the common canaliculus where it turns forward. Avoid this pitfall and false interpretation of a common canalicular obstruction by ensuring the lower eyelid is stretched laterally in order to help straighten this kink, and gently feel the cannula tip, explore the lumen and angle it slightly forward. Where a canalicular obstruction is encountered, the length of the lacrimal cannula, which can be passed beyond the punctum, should be recorded in order to locate the site of the canalicular obstruction from the punctum. In the absence of a soft stop with the tip of the cannula in the sac, then intra-sac irrigation is performed. Careful observation once again is made to note the proportion of this fluid that is regurgitated back, either through the upper canaliculus or lower. In addition, particular attention is also given to the presence of any mucus in this initial return of fluid. The presence of any mucus within this initial fluid return is highly suggestive of some degree of outflow dysfunction of the nasolacrimal duct. Although, in the absence of a mucocele, any mucus initially seen during mid-intracanalicular irrigation may no longer be present during the subsequent intra-sac irrigation. The differences encountered between mid-intracanalicular and intra-sac irrigation may be compared alongside those of the gentle probing in order to help detect or correlate with the presence of a partial distal common canalicular membranous obstruction or stenosis. Informing the patient that intra-sac irrigation with saline is commencing allows the clinician to gain a subjective qualitative comparison or a qualitative irrigation transit time between both sides by asking the patient to make a note of when they detect saline reaching their throat. Once irrigation of the contralateral side has been completed, the patient is then asked to report which side was faster. In the presence of obstruction in the lower canaliculus or punctum, probing and irrigation is repeated through the upper punctum. The patient is asked to look down and the upper eyelid is gently stretched laterally and slightly everted. The same lacrimal cannula is inserted into the punctum vertically, and at approximately 2 millimeters, the tip is slowly pivoted horizontally to pass through the horizontal canaliculus in the same way as per the lower canaliculus. No attempt should be made to overcome any stenosis forcefully, so as not to cause a false passage. The findings on lacrimal syringing should be recorded in a systematic and ideally a diagrammatic style to easily interpret. In addition, 4 observational components should be recorded. That of percentage of irrigated saline that was refluxed on each side, the presence of mucus in the initial reflux of saline, resistance to syringing, and on which side, right or left, did the patient report faster transit of saline to the throat. These provide a qualitative indication as to the presence of outflow dysfunction or stenosis. Even 5% reflux, for example, may reflect the presence of symptomatic nasolacrimal duct stenosis, particularly if associated with the presence of mucus in the initial reflux, slightly greater resistance to syringing on that side compared to the contralateral, less symptomatic side, and if the patient reports that saline was tasted later on the ipsilateral side compared to the contralateral side. This would be recorded diagrammatically as here is a video demonstrating this technique.
Okay, so mid-canaliculus, syringe, distract, advance, in the sac, syringe again.
The volunteer is asymptomatic and therefore only one side was syringed for the purpose of demonstrating the technique. She was found to be fully patent to syringing with no reflux or mucus and no resistance to syringing. Her findings would therefore be recorded as